Appreciate you being able to join us today, Dr. Slade. My name is Marco Martino. I'm the Health and Life Sciences Subcommittee Chair for Union League Club of Chicago's Public Affairs Committee. And we've taken a little hiatus. I think people are getting a little zoomed out. I think people are starting to get back out in person. But yeah, I'm glad we're able to have this timely discussion. So we want to just discuss the judicial challenges surrounding the COVID-19 mandates, and not only just the COVID-19 mandates, but also just vaccine mandates in general that, believe it or not, long precede all of us here. So as an introduction, again, I have Dr. David Slade here, and Dr. Slade is currently an assistant professor of infectious diseases and associate medical director of infection prevention and control at Loyola, as well as the chair of infection control and clinical care committee for Trinity Health. Dr. Slade completed a combined degree in law and medicine at Southern Illinois University and his internal medicine and infectious disease fellowship at Loyola University Medical Center. And again, Dr. Slade, the floor is yours, and I look forward to this discussion.
All right, thank you, Marco. Thank you for having me. Really excited to be here, and thanks everybody for coming. So today we're going to talk about the vaccine mandates and the judicial challenges to them. I want to start with some background information about really the legal basis, the basis of authority to institute public health measures at the state level and at the federal level. We'll delve into, what authority exists, what can be done, and talk in a little bit more depth about really what should be done in this particular instance. A lot of considerations here. I think this is really one of the most difficult questions presented by the pandemic, also one of the most important questions. I can't think of anything that has a greater impact potentially on the pandemic, but also poses a very real imposition on individual rights. So we'll talk about all of that, and we'll go through the actual legal cases that have been presented. Almost 2 years ago to the day, we admitted our first patient to Loyola University Medical Center with COVID-19. Since that time, we've had 6,500 patients who have been successfully discharged and survived COVID. As you know, though, many Americans, nearing a count of 1 million Americans, have died from this disease. We've certainly had many here. A lot of you, have either had COVID yourself, know someone who has, know someone who's had effects from it or died from it. And I know that I have, including family members and colleagues. So we'll start with the background here, public health measures versus individual rights. I want to start by touching on some really key points, some really fundamental considerations that we need to think about as we go through this. And here's an article that was published just yesterday by Wendy Parmet out of Northeastern University Law School, who is a very prominent health law scholar. And the title, I'm just going to put up here, Who Deserves Health and Who Deserves Freedom? A Recurrent Divide in the Supreme Court of the United States Vaccine Mandate Cases, alluding to the fact that one case was decided for the mandates in healthcare workers and the other against mandates for the majority of American workers. But just the title here encompasses, I think, that conflict between individual rights and public health measures. And it's very important to acknowledge that that exists. There's no question that any public health measure is going to place some constraints, some restriction on individual rights. How great or how little that is up for debate. But there's also a lot encompassed here that when we think about these vaccine mandates, we're thinking about the individual right to choose your own healthcare decision. We're also taking into consideration the impact that decision has on other people. This can be framed in many different ways. You can think about this as really, this is my own healthcare. This is my right, my decision to make a decision that impacts me. You can think about the transmission to others, and you can think about the more vulnerable population, what impact that has on population level transmission, and does that increase the risk for more vulnerable, older, immunocompromised, or other people with risk factors. These are all very important considerations I will say up front that I don't know that we have a perfect answer to exactly what those risks are, but we can at least make some estimates. Another really important component to the debate has been natural immunity versus immunization. Which is more protective, which is longer lasting? And there are a few different ways to look at this. I think the proponents who said that, look, natural immunity is an important aspect to combating COVID, have thought about it from the lens of, you're someone who's at low risk of infection. It's your right to, go out there, be infected, have a mild case, and then have natural immunity. Implicit in that, I think, is an assumption that the vaccine poses risk. And we'll talk in more detail later about, what risk it does pose. But really, I think the crux of that is that you can have natural immunity, have a mild infection, and not have to assume the risks of vaccination if that's not something that you're comfortable with. What are the benefits to vaccination? Well, you don't undergo the risk of the infection, whatever risk it may be to you, whether that be small or large. There's always a possibility that you could be someone who has a very severe, life-threatening or debilitating infection, and vaccination will protect you against that. Again, we don't have perfect answers to this. I think at this point in time, the latest evidence shows that both natural immunity and immunization provide very good protection. There have been maybe some conflicting studies about which offers longer lasting or more durable protection, or protection against different variants. And there's constantly changing information in this arena. And our ability to assess it is somewhat limited. When we look at antibody testing is rather imperfect. If we were to test you for an antibody level, we don't know really what threshold constitutes immunity. If we have a waning antibody level over time, how well does that correlate to susceptibility to severe infection? Again, we have information on this, but certainly not perfect answers. And then a really, really important question is, can mass vaccination decrease transmission? This is really the most important thing, isn't it? When we think about the goal of a vaccine mandate, we want to shut down the virus. We want to shut down its ability to spread, and we want to reduce the risk to the population. So can that be achieved? Now we know, and it's very well accepted, that vaccination cannot completely stop the spread of COVID. And that's been used oftentimes as an argument against vaccine mandates. I don't think that's the most important question. It's whether it can slow or significantly diminish transmission and save at least some lives in that respect. Again, we have some answer to this, but without having had a real vaccine mandate nationwide, without having a mass of the population vaccinated, I don't know that we'll ever know the true answer to how well we could have slowed or decreased the risk with mass vaccination. Okay, so with all those things in mind, we're going to jump into looking at the basis for regulating public health. Who has the authority? We'll look at it at the state and federal level, and we'll say that states traditionally have had a much larger role in regulating public health. The fundamental decision that informs this is Jacobson versus Massachusetts, a case that we're lucky to have, and this was a case of a vaccine mandate for smallpox, a dangerous, life-threatening, and communicable disease. And at the time, there was this man, Jacobson, who didn't want to get vaccinated. And he argued the same arguments that are being argued today, that he had a fundamental liberty interest found in the 14th Amendment that protected his right to make his own medical decisions. And here is just the text of the 14th Amendment. The state shall not deprive any person of life, liberty, or property without due process of law. So the plaintiff here argued that a compulsory vaccination law is unreasonable, arbitrary, and oppressive, and hostile to the inherent right of every free man to care for his own body and health in such a way as to him seem best. But the response to this was that this is outweighed by the public health interest, and that this liberty interest that we have is not absolute. It is subject to reasonable constraints for the good of society. And those are the two things that we have to weigh here. What is the threat to public health? How severe? And what is the weight that we lend to that? And so Jacobson ended up being the basis for really the police powers that we have today, the state's ability to protect the health, safety, and welfare of the people. And that power has stayed with the states. They still retain the bulk of authority to regulate public health. What are the limits on this power? Generally, this power should not be so much as to lead to injustice, oppression, or an absurd consequence. So it's not absolute. And we'll look here at some of the, as we've gone over the years, some of the limits that we found on the state police powers. If we wanted to challenge a vaccine mandate at the state level, we'd ask, is it prohibited by the Constitution? Is there something in the state or federal Constitution that prohibits it? Does it conflict with some other individual right under the Constitution? Is there some applicable federal or state statute? Is there a right to privacy that we can assert, a substantive due process? We can look to equal protection arguments under the law and the free exercise of religion. All of these arguments have been made in one way or the other throughout the pandemic. But now we're going to move to federal authority. And so we'll start by talking about Congress. We know that Congress has not passed a law requiring vaccines to be mandated. If they were to do so, they would have to derive their power from the Constitution. And this comes primarily from Article 1, either the Taxing and Spending Clause or the Commerce Clause. The classic case of the Taxing and Spending Clause is when the federal government wanted to set the drinking age at 21 and wanted all the states to set the drinking age at 21. And tied this to funding for the federal highway system and said that they would withhold that funding if states didn't comply. So this is one way that the government can pass these laws through the taxing and spending and by making them contingent on funding. The limit to this is that it can't be so cumbersome as to be completely coercive. The state must have some opportunity that they can say no to that. The second source is the Commerce Clause, the ability to regulate interstate commerce, and would have to be tied in some way to that. You'd have to say that vaccine mandates are related to commerce and that you're regulating commerce in some way. What we've seen recently under the Commerce Clause is that we can't compel individuals to engage in commercial activity. And this came to light under the ACA, where there was litigation over the Affordable Care Act. And we said that we cannot compel people to buy health insurance, cannot compel them to engage in commercial activity. So there are some limits, not a lot, but there are at least some limits. But we don't really get to that question, do we? Because Congress has not passed such a law. What we're looking at today is agency authority. So Congress delegates authority to its different agencies to pass rules and regulation. And what we're going to talk about primarily here is CDC, FDA, number one, number two, OSHA, and number three, CMS and HHS, Health and Human Services. So we'll start with CDC. CDC hasn't really been implicated in the vaccine mandates, but you might wonder if it's their role to do so. Their authority comes primarily from the Public Health Services Act, Section 361 here. And the text here is pretty much sums up what authority CDC has. They can provide for inspection, fumigation, disinfection, sanitation, pest extermination, primarily isolation and quarantine. And there's this mention of other measures. And the text of this is really, again, the source of their authority. This rule has been interpreted in a couple of ways, rather narrowly to date. And that is that, CDC can certainly impose isolation and quarantine where warranted. A broad interpretation would say that they can take any steps necessary, really, to prevent the interstate spread of infectious diseases. But the courts have found this not to really be the case. So CDC, to conclude on this one, is fairly limited. And I don't believe that they have anywhere near the authority to pass a vaccine mandate. OSHA is the first one that went to the Supreme Court. And where does OSHA get its authority from? From the Occupational Safety and Health Act. So they're tasked with ensuring occupational safety. These standards must be reasonably necessary or appropriate to provide safe or healthy employment. They have to follow the notice and comment process normally. So public has to have their option to weigh in, their time and their opportunity to give their opinion on this. With the exception being if we're under an emergency circumstance, OSHA can issue and did issue this emergency temporary standard, which does away with the notice and comment period. So the public loses their ability to weigh in. Switching gears here to Health and Human Services, or CMS. And here we're dealing really with regulation of healthcare institutions. And they're tasked with ensuring that the healthcare providers provide a safe environment for patients. And they can put in steps to ensure this, and they tie this to funding. So hospitals have to comply with these safety regulations. Otherwise, they lose their revenue, Medicare and Medicaid funding, which are a huge source of revenue for the hospitals. One such requirement, we'll give an example, is that hospitals maintain an infection prevention and control program. That's what I'm involved here with Loyola. And we look at everything from hospital-acquired infections, bloodstream infections, urinary infections, new and emerging diseases, medical device infections. And that's all closely monitored, and we report to CDC on that. So let's move right into the vaccine mandates. We talked about the basis of the authority, and now we're going to apply this to our current situation. I want to start with a case here. I'll start with a case. This is, I'll tell you about a patient that I saw who was a former healthcare worker, had a very severe case of COVID. This patient was in the ICU for several months, eventually recovered, survived COVID, but got out and was on oxygen for many, many months, is still on oxygen, very debilitated, went to rehab as a result, fell, broke a hip, had more surgery. And I put up some images here showing a normal lung. This is a CAT scan of a normal lung, and then a post-COVID lung. So we can see the destruction that COVID can do with this massive inflammatory response leading to scarring of the lungs and damage that can be very long lasting and even permanent in some cases. And this case is one that illustrates to me very well that even if you survive COVID, you can still have a very long course and many, many complications that stem from it. I'll give you some other examples. I've seen patients treated for COVID who got heavy dose immunosuppression and then ended up having severe bloodstream infections. I've seen Staph aureus in the blood that spread to the central nervous system, leaving a man partially paralyzed. I've seen someone else who reactivated blastomycosis, which is a fungal infection known as Chicago's disease, ended up not surviving that. So it's not just COVID, it's all of the implications, all of the injury and damage that can stem from it. When we first were in the first few months, I was sitting around with some of our fellows in the office, and we were really just learning about COVID-19 for the first time. We were all in masks, we were all in protective equipment, obviously very burdensome, a lot of anxiety. And I made kind of a half serious remark that, I hope I just get COVID. And so I have some natural immunity. This is before vaccines came out. And then I don't have to worry about it. As we moved through this, as I saw more patients, as I learned more about it, as we saw people lose their taste and smell for prolonged periods of time, then we saw, this long-lasting lung injury. Then we saw the neurologic complications, these manifestations of long COVID, people complaining of severe fatigue, long-lasting effects. I really started to say, wow, I want to avoid this and get vaccinated as soon as I can. So we'll move on then. We'll go back to the vaccine mandates. And I think, setting the stage for why people were in favor of vaccine mandates, with the situation that we're facing and wanting to really slow the spread, constrain this disease. And the hope was for herd immunity and that we could stop it in its tracks, which ultimately we couldn't. But, traditionally, where do we see vaccines mandated? We see them in schools, we see them in healthcare institutions, and we see them in the military. And that is what is, really our country's tradition, and we have precedent for. California did roll out a very controversial COVID vaccine mandate. So we've seen that as an example in the schools. Even more controversial because students, young children are a particularly low risk group. This is a nice, little bit slightly outdated image here, but we're seeing as of November, vaccine requirements across the country. And these are states that have at least some, all the ones in the black have at least some vaccine requirement. The dark blue is they've actually prohibited vaccine mandates, and the light blue is they've stayed silent. So really a smattering, a great variety here. So I'll highlight one case, which is Doe v. Rumsfeld, when we start to think about how do we challenge vaccine mandates. And that was a case of an anthrax vaccine, which was not yet FDA approved. And a military member was required to get it and said that, look, you are basically experimenting on me with this vaccine that's not been FDA approved. And the court sided with them. They said yes, but it was quickly overturned when the FDA later approved that vaccination. So that's really fundamental, really key, that FDA approval, thorough evaluation of the side effects and the risk posed by the vaccine is something that we need before we can require vaccines. So healthcare workers, we're required to get a number of vaccines. Hepatitis B, influenza vaccine, I have to get every year, MMR, measles, mumps, rubella. So that's not necessarily something new. COVID vaccine requirements in Illinois have targeted schools and teachers, requirements there, all healthcare workers. And then a vaccine or weekly test requirement was put in place for daycare centers, looking at protecting the children there. This spawned a massive lawsuits. We can look at one in particular, which was founded on the Illinois Healthcare Right of Conscience Act. This had broad language related to religion and moral convictions. This is designed really more to for people who objected to abortion. But the language was such that people were able to use a similar argument against the vaccines and were initially successful, prompting our own legislature to go back and amend this to add specific language excluding measures to limit the spread of COVID-19. There was then a well-publicized case at Indiana University required vaccines, and then this was taken up by the Chicago-based Seventh Circuit, which sided with them and said that the university could require vaccinations as a conditional to being enrolled. And the ruling was based largely on the Jacobson case, which again is fundamental for the states. And this is a state level case. Okay. Some states reacted differently, didn't they? Florida, Texas. What was shocking to me was that, not that this was controversial, but that some states came out and said, we feel so strongly that this is an individual right, we're actually going to ban vaccine requirements. And this, I think, was in response to an overreach. It was felt that the government was overreaching and that people needed to be protected in their decision-making. And so this was passed initially by executive order that no one in Texas could compel receipt of a COVID-19 vaccine. Certainly, you could make some legal challenges to this based primarily, I think, in your right to your personal safety. And again, this goes back to the really fundamental question, how much of a risk do people, unvaccinated people, pose to those around them? And this is what we need very good data on to make a well-informed decision. If we want to get down to really the, what sort of legal arguments would you pursue? You can look to the state constitution. We'll take Montana as an example, which ensures a clean and healthful environment. Some might make an Americans with Disabilities Act argument if you're a person with a disability, such as an immunocompromised condition, that you are a particular vulnerable person and that you need to be afforded protections, and that banning such things that are designed to ensure your protection should be illegal. Okay. So we've said that vaccines cannot stop the spread of COVID. But can they limit it? I believe that they can substantially decrease the spread. You're going to have some, asymptomatic infections. You're going to have some mildly symptomatic infections. If you have some pre-existing immunologic protection, we would really think that the viral load would be lower, that you would have less viral particles, at least in a majority of cases, and the overall effect to a largely vaccinated population should diminish, although not stop the spread of COVID. You might ask yourself then, how important is that? If you're going to inevitably come into contact with the virus, what does really slowing it do? Well, one thing that we have to look at that we can't forget about is whether our hospital system is overwhelmed. And that's something that we experienced firsthand here at Loyola, with the hospital being so full that we couldn't get in patients, a very difficult time finding patients, beds for patients coming in through the ER. And that must be taken into consideration, I believe, for any sound policy. How do we weigh that against the vaccine side effects? I always remember one of my teachers in medical school said that, any antibiotic can have any side effect. And I think the same is true for a vaccine. The data has shown that the vaccine is very safe. It's very safe and has very few side effects, but it's not side effect free. And, we have even seen some severe side effects. You could have anaphylaxis, so a severe reaction with a drop in blood pressure that's life-threatening. We saw this blood clotting with the Johnson & Johnson, which was very rare but serious and potentially deadly. This possible link to it, which perhaps has caused up to 6 deaths. We saw inflammation of the heart, myocarditis and pericarditis, and then this temporary paralysis, possibly with Guillain-Barré syndrome, all very rare, but not insignificant. So should you, someone who's at low risk of COVID, be forced to take that risk with the vaccine? The other thing that's come up is, people want to see the long-term side effects. Even if it's FDA approved and we have a good sense of the short-term side effects, what will this do to me in the future? Will this have some crazy side effect, alter my DNA? There's a lot of ideas out there, a lot of worries and a lot of concerns. And, how do we evaluate this? How do we properly, ensure people that this is safe over the long term? How long is required to evaluate the safety of a vaccine? Is it months? Is it a year? Is it 10 years? These are questions that I don't know that we have answers to. Although I would say that we probably do have enough information to say that this is safe. I'll tell you about another patient that I saw. A middle-aged woman came in, had her second dose of Moderna, had a very severe rash almost immediately. She came into the hospital, had a really prolonged hospitalization, was there for many days, I believe weeks, and had this severe reaction that we were all trying to figure out. Ultimately, we diagnosed as HLH, or hemophagocytic lymphohistiocytosis, which seemed to not necessarily be proven, but very highly suggestive that it was caused by Moderna. And this is a condition where it's an autoimmune phenomenon. Your immune system ramps up and starts attacking your own blood cells, your own infection-fighting cells, kind of turns on itself. Can be severe, can be life-threatening. The patient was treated. Ultimately, she's doing well, continues to follow up to this day, and has had no severe sequelae of it. But just an illustration that there are some very, very rare side effects, and we can't ever say that a vaccine is 100% risk-free. Now, what this comes down to, we have to balance that risk of vaccine against the risk of COVID, which I believe is far greater to the vast majority of patients. And I encourage all my patients and everyone I know to become vaccinated. So we took a little segue. And we'll come back to the immunization mandates at the federal level. We saw this come through in three ways. Number one, we had an executive order, which has been not really talked about as of late. This was the first thing to come out September 14, the federal contractor vaccine requirement. If you remember, President Biden issued this to say that anyone doing business with the federal government had to be vaccinated, all employees of federal contractors and subcontractors. And this was ultimately challenged and is still winding its way through the courts, but isn't expected to be upheld. It remains suspended. We'll likely reach a decision in April. Again, we don't expect this to be upheld. And now the OSHA rule. This was probably the biggest, rule that came out, the thing that was closest to really a national vaccine mandate. And there are a few things that were really important here and that we'll look at. What was the OSHA rule? It was passed in November. It required employers with 100 or more employees to ensure that the workers were fully vaccinated, or if they didn't, to test at least on a weekly basis. These tests weren't paid for by the federal government. This is not subsidized. And then required that these employers provide paid time for employees to get vaccinated, ensure all unvaccinated workers wear a face mask in the workplace. That's the OSHA rule. And then the CMS rule, which required that healthcare workers at facilities participating in Medicare and Medicaid are fully vaccinated. All right. So what was the implementation plan? This was all supposed to go live in January, but the lawsuits started rolling in. We saw 27 states immediately respond with litigation over this. It went to the U.S. Court of Appeals for the Fifth Circuit, and I want to talk a little bit about the lower court's response to this. We can see that, just a summary here, the executive order is on hold, the OSHA rule was overturned, and the CMS rule ultimately struck down. CMS was upheld. But what did the lower court start out by saying? When we'll look at OSHA here, they said that the OSHA has extraordinary power under its emergency provisions. And this is getting to the fact that OSHA issued this as an emergency temporary standard. They bypassed the notice and comment period so that the public didn't have proper opportunity to weigh in here. Extraordinary power, and that has to be exercised carefully. There's a massive financial burden. This has the potential to completely decimate the US workforce, particularly the healthcare workforce, and that could be very damaging. The mandate they felt was staggeringly overbroad. You know, what if you're just a trucker who is alone in his truck, or you're someone who works outdoors, you're not exposed to other people, you're not at risk of spreading this to anyone else. Why should you be subject to this just because your company has more than 100 people? And then they pointed again to the Commerce Clause, saying that it far exceeds the federal authority under the Commerce Clause. It regulates non-economic inactivity that really better belongs to the states to regulate. And that should belong to the states under the Jacobson rule. Okay. Now, the lower court also rejected the CMS rule. They said that it exceeds CMS's authority. Congress should decide these matters. It's a matter of huge magnitude, and Congress has to speak clearly here. This shouldn't just be relegated to an agency to decide. They said there was insufficient evidence to even justify mandating the vaccine. We've been living with COVID for almost 2 years. Why not take the time for Congress to consider it? Inconsistent with established precedent, CMS has encouraged but never mandated vaccines before, and that it also would have a negative impact on healthcare if healthcare workers left the workforce, an already thin workforce, because of this mandate. And I think something that's really important and that was highlighted by the lower courts is that federal courts have consistently rejected attempts by the federal government to exercise police powers under the Commerce Clause. They've always left it to the states. It's always been left to the states. This went to the Supreme Court. And in a controversial decision, they struck down the OSHA rule. They upheld the healthcare worker rule. So what was the reasoning here? Well, you know, kind of 4 points that the Supreme Court made. It exceeds the authority. OSHA is charged with ensuring workplace safety. But look, this is not just part of the workplace. This is something that impacts everyone. It's an environmental hazard. It's in no way specific to where you work. It's just everywhere. And OSHA doesn't regulate crime, and OSHA doesn't regulate air pollution. And this is just out of their authority. This is bigger than OSHA. It fails to account for workplace-specific risks. So back to that, you know, if you're someone who works outdoors and is at low risk, it doesn't take that into account properly. It's an unjustified use of the emergency temporary standard. They said it's not an emergency, and we've been living with this for quite some time. Now, that to me, doesn't necessarily mean it's not an emergency. You can be in a constant state of emergency, and who's to say when an emergency starts or stops, but perhaps there's some truth that there was a lot of time to consider these things. and for Congress to act on it. The dissent, and finally a separation of powers doctrine, that the states, again, should maintain that authority, the police power, as they traditionally have. The dissent really disagreed. They said that there's not only the authority under OSHA to regulate this. People have to go to work. You don't really have a choice whether to go to work. And so OSHA should do its part to protect you while you're there. And that not only do they have the authority, they must, exercise that authority to protect people. And it's not the court's role to take that authority away. The court ruled differently on the CMS rule. And why did they do that? Well, I think this goes to the fact that, when we look at what power Congress has delegated to each agency, the court here felt that while OSHA hadn't been delegated the proper authority, CMS had been. And this is because, really going back to the fact that they have those infection control measures in place, the CMS has already said that hospitals need to protect their patients, that, we do all these things to protect our patients. How is the vaccine requirement any different? We already require those other vaccinations, so that's consistent. A vaccinated workforce will prevent healthcare staff shortages. So this is the exact opposite of what the lower court said. Lower court said, you pass this vaccine mandate, you're going to chase away all your healthcare workers, so we won't have anyone to care for patients. The Supreme Court said quite the opposite. They said this will actually keep our healthcare workers healthy, keep them there, taking care of our patients. And so, we can distinguish this from the other rule in that Congress here had a more express delegation of authority. Again, there was a dissent in this case, that CMS has never done this before. Well, the majority opinion said, yeah, but CMS has never faced these kinds of circumstances before. This is not something that we've seen, and so we have to rule accordingly. All right, I want to tell you about one more case. We've looked at the controversy over vaccine mandates, the pros, the cons, and we'll wrap up with some conclusions. As all of this was being debated, Omicron struck. And we thought that we were all, heading out of COVID, and all of a sudden there's this new variant. And we were, it felt like we were right back to March of 2 years ago. It wasn't the same, but it felt the same in some ways. But it was different because we had a vaccine this time. And as we saw this crush of patients come in, and we saw some people very steadfast in their willingness or their desire not to be vaccinated, and even in some cases not to be treated, I'll tell you that I saw some patients myself that I would go and see every day in the ICU, and had to wonder if that decision led to some really avoidable deaths. We saw a lot of unvaccinated people that I think could have survived. In these conversations, people say, well, that's your right. That's your right. If you don't want to get vaccinated, you have to choose what's the risk to you, what's the benefit and the risk. And I believe that. I believe strongly in autonomy, that you have those rights. What we really need to take into account here is keeping the hospitals open, keeping the beds open. When we reach such a point that there are so many people seeking care, that we're in a pandemic situation, a global, massive, threat to our health, and that we no longer have hospital beds, that might be the deciding factor of whether you need to seriously consider a vaccine mandate. Okay, just to draw some conclusions here, I don't think there's any easy answer to this. This is a nice summary of what we can take into account here. What's the magnitude of the problem? COVID's been vexing in that respect. It's unpredictable. We can look at your risk, but you just don't know. Are you going to be someone who has a mild or asymptomatic case? Or are you going to be someone who has a severe case? I've seen low risk people in the ICU for months. I've seen, young pregnant women with serious cases and die. I've seen a lot of people be fine and have no problem. And like I told you, I've seen side effects from a vaccine. So what's the magnitude of the problem? What's the level of confidence in the vaccine's safety and effectiveness? We have to look at this objectively. All right, do we have alternative strategies? what's the utility, what's going to be the benefit of the mandate compared to alternative strategies. And I really believe that we don't know how much mass vaccination would have decreased the spread. Very hard to say, but we know it would not have stopped it completely. What are the costs of mandatory vaccination? And if they're disproportionate, we should consider other strategies. All right. Ideally, to me, we'd see high levels of vaccination without having to mandate. I think vaccine mandate is an extreme step. It's very onerous. It takes away, it truly does take away, a fundamental right to autonomy over your healthcare decisions. I believe in some cases it may be necessary. And I think, I leave it up to you to decide if you think COVID ever rose to that level. Thankfully, now we're heading out. I'm really happy to say that our case counts have dropped. We have no patients in the ICU here at Loyola. But, the lessons to take away, I think we really need a sound plan. We currently have, a fragmented system that relies on local and state healthcare departments. Looking to the future, I think we all need to come together and decide what is going to be the role of the federal government, or rather, what is going to be the cohesive approach of our states. So we need a clear legal and regulatory framework, a coordinated response, evidence-based policy without bias, sound education, and leadership. I'll stop there and I'll take any questions. I see one here in the text here. Were there any cases out of the TB quarantines, as distant relatives spent a long time in a TB sanitarium? Yeah, TB is such a good comparison where we can look to, I think, precedents in other contagious diseases. And, we really do regulate that. We compel people to be isolated or treated for TB. We've had directly observed therapy by our public health department. So yeah, I think we do have some precedent there. What I'll say is that if we distinguish, the state has a lot of power. I think the state can absolutely impose these mandates, but the federal government cannot.
I have a question, but I also want to let others ask first. If there's any questions, please put them in the Q&A. Or maybe while you guys are typing, I can ask my question at this slide. So, and this is, I did not really provide the intro. I'm also in law school at 3L, and Dr. Slade came and spoke to our class as well. So one of the issues in just learning the health law route, the health compliance route, is the effect of, we'll say, mandatory vaccinations or mandatory anything in healthcare and racial disparities. So unfortunately, we can spend a whole other hour webinar on this, but unfortunately, the atrocities that have been seen in communities of color with regards to mandatory this, mandatory that, and unfortunately the distrust that came from it. I guess, how do we address, say, confidence in the vaccines in communities of color, I guess, is the very long-winded but shortened question.
Right. Yeah, I think it's,
please.
I think it starts with engagement, education. I think we have to look to the sources of that distrust. I sat down with a reporter for NPR who had done a lot of work on this recently. And, we were talking more about some of those same disparities as it pertains to the oral therapeutics. And she had a lot of questions about who's receiving those, and are there disparities in that? But it's very similar to what we saw with the vaccine. So, I know there were efforts in Chicago to reach out to those communities to provide for free vaccinations, but then we have to overcome the hesitancy beyond that. So, I think, setting up outreach programs, free clinics, education, here in Maywood, one of my mentors a long time ago was set up our Access to Care clinic, and it's a completely free clinic that provides, here in Maywood, we've been predominantly an African-American community, shifting more to kind of a Hispanic community in more recent times. But, I think having those free clinics in existence so that we already have a primary care network set up, and so there's somewhere people can come to get that information, and they're not just on their own. I think that's really key, that we need some structure in place.
Yeah, I agree. And obviously, this issue can't even be addressed unless there's access, especially in communities of color. So I think that's great. It's great to hear. And if you see, there is a question in the chat as well. I mean, in the Q&A that just came through.
Great. Let me take a look. The patients who chose not to be vaccinated and didn't mind taking the risk of dying, were they asked why did they come to the hospital and tie up a bed that could have been used by someone who chose a more appropriate course? That's such a difficult question, important question. This was when I'd have these conversations, people, you'd say, well, it's my right to choose, but you have to ask that question, if you choose, then are you going to choose to come to the hospital? And that's such a hard question, isn't it? Because you can't say, don't come to the hospital. It's that moment where maybe you realize that I should have gotten vaccinated. But I think that's where we need to educate people to say that it's not just your decision whether you're going to protect yourself. It has an impact on other people's care regarding COVID, other people's care regarding all of the other things they might come to the hospital for, and whether they can seek care. So we have to have that message out there. That's where we need leadership. That's where we need, I think, our local public health, our politicians, everyone to get that message out. Yeah.
Honestly, for the interest of time, maybe I'll ask one more question. If there's any more, please fire them off in the Q&A. And this might be more of a polarizing question, so if you want to maybe deflect it, that is okay too. We have heard, I think there was even Illinois, I think he was Illinois, part of the House. I don't think it was the Senate, but regardless, a lawmaker in Illinois, and I think the governor of Colorado also mentioned this. How do we factor in, as you're kind of talking about this, rationing care, especially in certain situations where, like you said, the ICU beds are near or at capacity, ER beds are near or at capacity. Has that ever been discussed? And I know that can be brought up.
Absolutely, Marco. And, I'm not afraid of controversy, so I'll weigh in. I've had to be part of some of those conversations, at a much lower level. I've been part of creating a lot of the standards to distribute the therapeutics, and how do we distribute those in an equitable manner, and how do we not discriminate because we have a finite supply. And so we can look to the highest risk people for that. We can make sure that we don't discriminate based on, race, religion, color, or even age. We had to look and say age is a risk factor, but age has no impact on how we value your life. But there were those times early on where, we were looking at ventilator shortages, and, we had a plan in place for really rationing those. And, there's no easy answer. We had risk management involved. We had ethics involved. You have a number of strategies. Who's the highest risk? Who's the most critically ill? Is it a first come, first serve basis? I think with all of these things, despite our best efforts to create some sort of, fair and equitable system, what it's boiled down to is almost something approaching a first come, first serve basis. It's nothing we ever want to see. I think we were lucky. We really, came close to that. We were at the precipice, but we never had to make those brutally difficult decisions. So we need to do everything in our power to avoid getting there.
Yep. Perfect. I think that makes sense. It's not so much a rationing per se, but a first come, first serve. And so completely understand that. And then do I have one more question, and then maybe we can call it at that.
All right. What's your opinion of Dr. Fauci's performance during the pandemic? Do you believe the CDC's credibility has been discredited? It's been stated that scientific data released was highly selective. I was reading about that, and it struck me because what my first response to that was we should never be in a position where we're cheering on one side or the other. We shouldn't have to say, look, the CDC wants to promote this side of it, or I'm on this side of it. We just need to look to the truth. If the vaccine didn't work, okay, that's okay. We can say that. Dr. Fauci, my opinion is he's been, I think, highly controversial, but need not be, and he spoke at a conference I was at. I found him to be not very controversial. He stated some facts. I don't think that he's had any massively insightful things to say at times. I don't think he's had any hugely controversial things to say. I tell you, my dad actually used to work with him way back in the day, and I know he's okay. He's fine by me. I think the CDC has been a little bit villainized. They have had their faults, you know, they have had their blunders. They've been very confusing, even to me at times. But I don't think they're malintentioned. I don't think they've ever, you know, I've talked to people, CDC officers, and I think that everyone is on the right page. We have different perspectives. You think about yourself as a public health perspective, you're doing your best to protect the public health, and, you know, other people aren't there feeling it, and they just want to, you know, have their freedom and their liberty and live their lives. And I understand both sides. So CDC has not been perfect, but I think they've not done anything, you know, tremendously bad either.
Yeah, I would agree. I think one thing that, regardless of how people feel about maybe Dr. Fauci or just the response or different administrations, is when you have someone who's as visible as he is, who is putting himself out there, he becomes a scapegoat, becomes the villain. So I can completely understand that. It's he's consistently come on and talked. So
yeah, it's a great point. It's bound to be polarizing. Mm-hmm.
Yeah, you know, and then it's easy to go after to not go after people who are not as visible. So regardless, very unique times that I don't think many of us have ever gone through. So Slade, appreciate your time. I know things are always busy in healthcare, so really appreciate your time to speak to us, and hopefully we can be in touch again.
Definitely, Marco. It's been a pleasure. Thanks a lot.
Thank you.
All right. See you later.
Bye-bye.